Dr. Edo, may we start our session? Hello, Dr. Edo. Dr. Edo, can you listen me, please?
Uh, yes, your voice is quite small. It's difficult to hear, even though my volume is already maxed out.
Okay. How about now?
Still very small.
Still very small. How about now, Dr. Edo?
Sorry, can you repeat?
How about now? My
Oh,
voice
now
still
it's
small.
now it's good. Now it's good. Now it's good.
Okay, may I start the session, Dr. Edo? Okay. Okay. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, ladies and gentlemen. Welcome back to the International Virtual Conference on Education, Science, Technology, and Innovations 2020 or IVCESTI 2020. For this afternoon, we will have the first plenary session with Dr. Pil Edo S. Jaya, SI Psycholog. We would like to invite our moderator to handle this session, Miss Yola Eka Putri, SPD CM, NNLP. Miss Yola, please welcome.
Okay. Thank you for the chance, Miss Syria. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. The honorable speakers and all the participants that been watching us or gather with us through Zoom and YouTube Live. It's really my great pleasure to become a moderator in this session because we have an incredible speaker here. For all the participants who want to ask later about the topic, you can add the question on the Q&A tools on Zoom, or you can leave a comment in live chat on YouTube. So the speaker for this session is Dr. Phil Edo Esjaya, SI MSci, psycholog. Good afternoon, Mr. Good afternoon, Dr. Edo. Thank you for your attendance.
Good afternoon.
Okay, before we invite Mr. Edo to the virtual podium, I would like to give a general introduce about him. So Dr. Edo is a clinical psychologist whose main research interest in the etiology and mechanism of psychosis, and he hopes to someday that he can discover a strategy that can be applied to prevent psychosis. He has published several peer review articles on the topic of psychosis in the leading journals of the field, such as Schizophrenia Bulletin, Schizophrenia Research, and Psychological Medicine. He is also a reviewer for journals that are focused on psychosis, such as Schizophrenia Bulletin and Schizophrenia Research. But he also on psychology and psychiatry in general, such as cognitive therapy and research, European psychiatry, social psychiatry, and psychiatric epidemiology, and also psychiatric research. So please welcome Dr. Edo. Time is yours.
Thank you thank you very much, Miss Yola Eka Putri. Thank you so much for your kind introduction. Thank you, Miss Afni, for inviting us and be a moderator. I would also like to thank, of course, Bang Ifdil, who approached me personally to present today. So now I'm going to go share screen. Right. Okay. So today I'm going to present about psychosis studies in Indonesia. Here I'm representing from Faculty of Psychology, Universitas Indonesia in Depok, Indonesia. And I'm also the editor-in-chief of our journal in Universitas Indonesia called Makara Human Behavior Studies in Asia. So a bit of my profile. So I'm a lecturer and I'm also a consultant and psychotherapist at the teaching clinic at the Faculty of Psychology, Universitas Indonesia. And I also made my own clinic in Jakarta called Indonesian Psychological Healthcare Center. And my main research is, as have been introduced, but psychological mechanism of psychosis. But for my clinical practice, I see mostly other types of patients, depression, anxiety, panic disorder, eating disorder, schizophrenia, and lately I've been getting a lot of cases of borderline personality disorder. So this is what our university looks like, and that's where we like to hang out at. It's called Taman Akademos. We have 30 slides today, and the outline is this. So first we'll be talking about an overview of psychosis and schizophrenia, and then there'll be then I'll talk about my project. It is a longitudinal online survey with ecological momentary assessment. And then lastly, I will talk about a case report on using CBTp on psychotic patients in my private practice. So a little bit about schizophrenia. So in ICD-11, schizophrenia is a disease. So there's disturbances in multiple mental modalities, including thinking, such as delusion, disorganization, perception, self-experience, cognition, volition, affect, and behavior. So as you can see that it is a disease that affect all aspects of the human mind. So it's a really severe disease. And one of the highlight is that a person with schizophrenia should have persistent delusion, hallucination, thought disorder, and these have to persist for at least 1 month for the diagnosis of schizophrenia to be assigned. So that is the disorder. But then how about the symptoms? How about psychosis? We know that, for example, insomnia, that is difficulty to sleep, needs to be persistent for at least 2 weeks to be diagnosed as insomnia. But suppose that you have problems sleeping for 1 night, and that's okay, that's normal. But then what kind of psychotic experiences is normal? We don't know that at all. So that's what my current research is about. So first, I guess for people outside the field, it could be kind of a shock to say that symptoms of schizophrenia or symptoms of psychosis can be normal. That is, auditory hallucination can be normal. I guess that's a shock to a lot of people, but it's actually not a very new idea. It was first proposed by Strauss in 1969. And the continuum of psychosis does not mean the continuum of disorder. So here you can see graph C. In graph C, it is shown that most people don't have any psychotic experiences, and only few have frequent psychotic experiences. But then quite a lot of people have a little of psychotic experiences. For example, auditory hallucination of people with schizophrenia would be, they might experience it the whole day. But then for people without schizophrenia, maybe healthy individuals, they might only experience it once or twice in a year, and the type also looks different. So auditory hallucination for people with schizophrenia, yeah, the type could be something like the voices speaking to them directly, but then for healthy individuals, the type could be just feel like, oh, somebody's calling at us, like, oh, somebody's calling my name, and then I turn around and then there's nobody. So that is already a type of auditory hallucination, but then the normal one. Now the question is, if we experience that like once a year, that's definitely normal. But then how about if it's once a month? How about every day? Is it still normal? So that's the question. And that's what I hope to answer with this project called Longitudinal Online Survey with Ecological Voluntary Assessment. It was, I presented a bit of this project also, I think 2 years ago, also invited by Bang Ifdil. Now I have some new results from this project. So I suppose not everybody who was in the conference 2 years ago attended my presentation here. So I'm just going to talk a little about it. First, there have been many known risk factors and psychological mechanisms of psychosis. But we don't know the time frame by which the mechanism operates. We don't know, for example, suppose that X causes psychosis. Will it cause psychosis within a week, within a month, within 2 years, within how long? We don't know the answer to that. So we might think like, oh, bullying is bad, so we have to prevent bullying. What should we do? But then we don't know, is it one act of bullying for 30 minutes enough to make changes? Or it needs to be continuous. So the question is about dosage. So, but then there has never been any study on time interval assessments of symptoms and common mental disorders. So, and also the average episode of various types of psychotic symptoms are not known. So the baseline, there's a lot of measures. First is gender. And then we also ask for previous mental disorders that have been or are being experienced by participants. Other types of mental disorders that's experienced by the participants' family members. That is to assess genetic or hereditary condition, and then current living status, current relationship status, romantic relationship experiences, and experiences pertaining to substance abuse, because these are all related questions for to assess psychosis risk. Then we have more measures: social comparison, loneliness, social undermining, ostracism, schema, bullying experiences, adverse childhood experiences, minority status, and also perceived discrimination. So all of these are repeated. But the ones with the asterisk is only administered during baseline, because minority status won't change. Adverse childhood experiences already passed, so it won't change. So we don't need to ask the same thing day to day or week after week. And then we also assess common mental disorders, especially depression, anxiety, somatoform, alcohol dependence, eating disorders, and then psychotic symptoms, positive and negative psychotic symptoms. We assess this in all assessment. So baseline, 7 days, and then 4 weeks, and fortnightly. There is every 2 weeks, and also 6 monthly assessments. The data that I'm going to present is on what we recruited from November 2018 to March 2019. So who accessed the surveys? There's like 3,000 access, and then by the end, only 499 completed it. We have 35 being excluded. 3 were not serious, so they admitted that they were not serious, and underage is 32. So 32 of them said that they were below 18 years of age. So in the end, 464 participants analyzed. Most of them were female, young age, and quite a large portion of them reported that they had a mental disorder diagnosis. Quite a significant portion reported that they have a psychosis diagnosis. So first, I want to provide some results. So we here as a bachelor thesis student of mine published his paper in the Universitas Negeri Padang journal called Counselor. Here we analyze the data looking at how minority status can impact on psychotic symptoms. And we showed that minority status impacted on psychotic symptoms via perceived discrimination. This has been shown before in the Netherlands, and we replicated it here in Indonesia with exactly the same questionnaire, and we found exactly the same results. Likewise here, this is also a replication of my other study in Germany, published in European Psychiatry. Here, my bachelor thesis student published her findings in Counselor, and this was actually voted as one of the best paper in Counselor by Bang Ifdil. So thank you very much, Bang Ifdil. Here we found that childhood trauma has an impact on psychotic symptoms, and it travels through negative self-schema. So when you have childhood trauma, then you have lower quality self-esteem, and with that, you get psychotic symptoms. Now, that is the baseline analysis, so simple mediation analysis. Now for actually the aim of this project, that is ecological momentary analysis of psychosis and social exclusion in daily time interval. So the design of the analysis is something like this. So we assess social exclusion every single day. Paranoia, that is a common psychotic symptoms, thinking that other people are following us, thinking that there's a conspiracy against us in the office, for example. So very normal paranoid thinking. So it's on the direction of psychosis, but not really, still very normal. And we assess everything day after day. So here, as you can see, there is 6 hypotheses on each. In total, there is 12 hypotheses that we are being testing. So first, we tested whether baseline social exclusion baseline paranoia predicted paranoia on day 1. Then we look at baseline predicting paranoia on day 2, on day 3, 4, 5, and 6. And also for social exclusion, likewise, social exclusion predicting paranoia on day 1, on day 2, day 3, day 4, day 5, and day 6. So the idea is we want to know, suppose that somebody gets paranoid or get not paranoid on day 0, how long will the paranoia stay? Will it stay until the next day? Or will it stay for 3 days? Or will it stay for the whole week? So once you're paranoid, you're always paranoid. We don't know that. And social exclusion, suppose that somebody excluded us, for example, today, will we get paranoid today and tomorrow, or until the next day, or the whole week? So that is the question that we are trying to answer here. Here, you can see that the asterisk is is statistical significance, and the graph here we used Cohen's d. So baseline to day 1, the effect is 1.4 Cohen's d, and then baseline to day 2, it's also significant. That is around 0.8, and then day 3 is still also very large at above 0.8. So we can say that paranoid thoughts in a given day have an impact on levels of paranoid thoughts on up to the 3rd day. On day 4 and day 5, day 6, it's difficult for us to say because we don't have enough sample. So there's no statistical significance, and the results are not too stable. Here, that is in the previous slide, that is paranoia regressing on paranoia. Here it's social exclusion on paranoia, and we can see that social exclusion on a given day has a strong effect on the same day, and the effect reduced on day 1, even though it's still large and still significant. But then by day 2, there's nearly no effect of social exclusion on paranoia. Of course, day 3, 4, 5, and 6. Now, what's interesting is that a lot of people, especially people who work in the in more of a biological sense, they always say that psychosis is largely a biological disease, and that the social consequences is a result of the disease. So if we treat it biologically, then all the social ailment will disappear. But here we found that nobody get excluded because they are being paranoid. None. That is from baseline to the same baseline, or baseline to day 1, and so on. So the expected results that we complete from the whole analysis is to give an estimate on the average length of various types of psychotic symptoms in healthy, clinical, and psychosis population, and also to understand the time interval by which psychological mechanism of psychosis occurs. And hopefully this may help with CBT session planning and dose planning. Because we know that, for example, being excluded has an effect for up to 1 day, then maybe a therapy session would need to be maybe more frequent than once a week, or something like that. Lastly, I want to share with you a case report on one of my patients. Of course, this patient is anonymized, so and it's also a bit of a combination of other people. So the name of the case for today's just use a common name in English called John, male, 30 years old, unemployed, dropout of Bachelor of Psychology, schizoaffective disorder, first onset is 2005, at 17 years old, took antipsychotics from 2012 to the present day. October 2017, there's only one voice with haloperidol, but then when I do intake, we are trying to work on that one last voice because previously there were 7 voices. Our session ends on November 2017, partly or mainly because of financial condition, but we have covered a lot of grounds. So here's a long symptoms and treatment history. Just quickly, just wanted to say that this is quite a, how can I say, this is quite a bad a bad case, so had attempted suicide, was depressed, and then had changed psychiatrists, had changed clinical psychologists, and so on and so forth. So this is my case formulation. Could be true, could be not, but it helps. It helps me doing the therapy. So first, he has a lot of negative environments, such as being unemployed, like in France. He's old, but still living with parents, has a strong negative schema that he feels useless. And of course, if one feels useless nearly all the time, one will be depressed and anxious. And then because he's too depressed and too anxious, he got a lot of auditory hallucination. For example, you're useless, kill your dad, and so on. And then functioning problems. And of course, when you have a lot of voices speaking to you, saying that you're useless and you have to kill someone, of course, you cannot function properly. You cannot work, you cannot hang out with friends and stuff. So the techniques that I use is this. So first, psychoeducation, teaching them a whole lot of the models, of the theories, telling him how to be in control. So once he knows the science, then we can work together to apply the science. I also gave him a program of behavioral activation, that is to eat properly, to sleep properly, to do some kinds of sport properly, very much tailored to what he can do. And then we also have mood monitoring. I tried to get him to monitor like when he's depressed, when he's anxious, and then from there he learns how to associate between his symptoms and his mood. And then lastly, I do some kinds of cognitive restructuring on dysfunctional thoughts related to his mood. So I told them, hey, if you think that way all the time, you will always feel depressed. You need to think in a more rational way. And lastly, I applied the technique of working with voices. First, I try to identify the voices, and then I talk with the voices. And then I trained him to talk with the voices in public. So the result is like this. So pre-therapy was pretty bad. As you can see, the depression is bad, anxiety is bad, negative self is bad, negative other is bad, hallucination is bad. But after the therapy, what has largely improved is only depression, anxiety, negative self schema, and negative other schema. Hallucination has also improved, but nowhere near normal, nowhere near good. So like from 35 to 22, he still hallucinate like every day. So discussion seems that auditory hallucination seems to cause complaints only when it is distressing. So even though by the end of the therapy, his hallucination score is high, he's okay with it. He doesn't find it to be problematic. So I find that to be interesting that high symptoms may not correlate directly to strong complaints. But then no complaints about hallucination, which is good, a success in the therapy, does not equal to functioning because he still have basic problems such as hygiene and grooming. So yeah. So take-home point of my presentation today is first, we found that mechanisms of psychosis seems to apply universally because findings in the Netherlands and in Germany seems to apply to here in Indonesia, because maybe partly because we use the exact same questionnaire, and those who conduct the study is me, so same person. Also, therapy techniques seem to apply universally because I use completely techniques from Europe, and then effect of risk factors to psychotic symptoms are time dependent. So it is not correct if we say that, oh, be careful, don't get bullied, because if you get bullied, you'll get stressed out. As if once being bullied, that means they will be stressed out in their entire life. Definitely not like that. Likewise with childhood trauma, likewise with all kinds of risk factors, they all seems to be time dependent. And the reverse, that is from symptoms to social factors, we found it's either negligible, for example, maybe it doesn't work that way, or it takes longer to be observed, so it cannot be observed in a week, because our data point that we have analyzed is only for a week. So maybe suppose that a person gets paranoid and becomes annoying to their friends, it might take him to be more paranoid and to be more annoying maybe a couple of weeks or a month or something for their friends to start leaving him. So maybe 5 days, 6 days, maybe it's not enough. So the friends have not reacted yet. Could be. So I guess that's the end of my presentation. Thank you so much for listening, and I give it back to the moderator.
Okay, thank you, Doctor. It's for the interesting speech. It's because of our time is limited. We should end our session soon. So, ladies and gentlemen, thank you for your participate into this session. I hope the wonderful speech from Dr. Edo could be useful for ourselves, and then society, and then nation or country or other people. Thank you, Doctor. We can end this session.
Okay, thank you so much, Ms. Yul Eka Putri. You've been very kind as a moderator.
Okay, thank you.